Whilst MDMA and psilocybin are still penned up in the stables, ketamine is racing ahead. If you can believe Wikipedia, then there are already more than 2,500 ketamine clinics in the US alone, but only 20% of those include therapy. Why is this? Dr. Lowan H. Stewart is a specialist emergency physician and pioneer of ketamine therapy, opening the first private ketamine clinics in New Mexico and Norway, and the first public ketamine clinic in Scandinavia. He is the medical director of Axonklinikken, a medical consultant in a range of psychedelic clinical trials, and a founding member of the Norwegian Association for Psychedelic Science. Here today to talk to us about ketamine, the psychedelic elephant in the room. Please welcome Dr. Lowan H. Stewart.
All right, thank you very much. Looks like there's some funky stuff going on with the slides here. That's okay. Robin Carhart Harris recently posted on social media, "Ketamine is not a psychedelic." He was focusing on some of the differences between ketamine and the classic serotonergic psychedelics. For good reasons, there are differences, and there's also a total Wild West of ketamine in the United States today. But I would suggest that instead of focusing on the differences, we focus on the similarities in terms of the phenomenology, the mechanisms, and the role that these drugs can play in the treatment of mental health disorders and in our healthcare systems. And I think this is important in terms of the implementation of psychedelic medicine in the world today. So what is ketamine? It's actually a naturally occurring molecule that is produced by nature, produced by the fungus Piconia chlamydiaspora. It's not a great name. I drop the chlamydiaspora when I'm talking to patients. I do think that, like Paul said earlier today, I think probably all of the psychedelics are eventually going to be found somewhere in nature or the universe. So ketamine was originally synthesized in 1962 as an alternative to phenylcyclidine as an anesthetic. That's PCP, or angel dust. It's an NMDA receptor antagonist, and it was first tested on humans in 1964 on prisoners. That's how we did research back in the 60s in the US. And it was originally labeled as a dissociative anesthetic, referring to this out-of-body sensation that most people experience, feeling like you're detached from your body, but you're remaining conscious. This, I think, is an unfortunate label because it focuses just on one negative valence characteristic of the experience, similar to the other terms we used to use for psychedelics, psychotomimetic or hallucinogen. It was FDA approved in 1970 and became one of the most widely used medicines in the world. It's on the WHO list of essential medicines. And 1970 was also the beginning of the first and hopefully last psychedelic dark age. So all these other psychedelics were banned, and yet the same year we have a medicine approved for use. So for the following decades, it continued to be used in psychedelic-assisted psychotherapy in Iran, Russia, throughout the Americas. The first published report was actually of using ketamine for a mental health disorder was in 1973 out of Shiraz in Iran. They treated 100 patients with a variety of anxiety and affective disorders. The patients reported, "I was in a different world, seeing wildly events which led to my illness. My life marching in front of my eyes, flying and facing the forgotten memories." So since the early 70s, it continued to be used in psycholytic, abreactive, psychedelic-assisted psychotherapy models. But modern evidence-based medical research started in the 1990s at Yale, looking at the neurobiology of psychosis and looking at the NMDA system. And I think partially that has something to do with the way that these two pathways between psychedelic and the biomedical models sort of diverged because of that early research. The first randomized controlled trial was in 2000 for ketamine for depression, and it's been used increasingly widely throughout the world for that use, but primarily in the biomedical model. So depression is the leading cause of disability in the world today. As Will said earlier this morning, he talked about the STAR-D study. Even after treatments with multiple antidepressants, there's still so many people that continue to suffer from depression. And we call this category treatment-resistant depression. And it's interesting because they're not resistant, we're not using treatments that are effective. Every year, almost 1 million people kill themselves. That's more people than die in every war and every natural disaster combined. And yet, since the discovery of electroshock therapy about 100 years ago, all the new treatments have been less effective until ketamine. So there's been a lot of excitement about ketamine for the treatment of depression because of the very high effect size, so it's really effective. It's extremely rapid, so people have response or remission within hours to days of treatment, as opposed to antidepressants, which can take weeks to months. About 2/3 of people with what they call treatment-resistant depression have a response, and about 1/3 go into complete remission. And the therapeutic effects are durable, long outlasting the metabolism of the drug in the body. The largest, most recent study comparing ketamine to the gold standard of electroshock therapy showed that ketamine was non-inferior to it, and in fact outperformed electroshock for younger people and non-psychotic depression. In terms of anti-suicidal effect, ketamine also completely causes remission of any suicidal ideation in about 60% of people within a couple days of ketamine treatment. And this effect is independent, partially independent of the antidepressant response, and also transdiagnostic, so independent of the presence of a diagnosis of major depressive disorder, for example. Actually, before I go to that, I'll tell the story of my first patient. So this is the very first patient I've used ketamine for a long time, but just over the last 10 years, I've been treating people for mental health disorders. The very first patient I treated was a young man suffering from severe depression. The night before his first treatment, he had been standing on a bridge. He had thrown away his keys, his phone. He had left his dog loose in the woods, and his friends found him standing on the bridge. The next morning, just hours after his first treatment, again, he was standing by the water. But this time he was standing in front of the ocean. He was smiling, and he was in complete remission. So we've heard various definitions of psychedelics. What is the definition of a psychedelic? I'm going to answer just with a sort of like a Zen koan, just with this sign. This is actually an actual road sign in the city where I went to medical school in Albuquerque, New Mexico. There's two parallel streets, Universe and Rainbow. It's true. New Mexico is a magical place. So what is the phenomenology of ketamine? It's incredibly variable. So totally dependent on the person, on the individual experience. But some of the variety of experiences people can have are awe, ineffability, altered affect, altered perception, sensations, synesthesia, altered cognition, sense of space and time, an expansion of the boundary of your conscious awareness, which could be oceanic boundlessness, a transpersonal experience of connection, but also on the flip side, a near-death experience or anxious ego dissolution, being stuck in the K-hole. People can describe the overview effect, that profound sense that you're a small part of a larger interconnected world, but really variable. Some people just describe a meditative experience. Sometimes I describe it as, or it can be described as intravenous meditation. Being conscious without any clear thematic content or autobiographical content. That's how my personal experience with it is. I never have seen anything. I just experienced it as a deep meditative experience. A vague sense of being in the very last scene of Interstellar in the black hole. And one time I heard the words of Ram Dass saying, "Be here now." But other than that, just meditation. So there's a significant qualitative overlap with the serotonergic psychedelics. But so very high diversity of altered states. One of the characteristics that's most different, I mean, they can be experienced with other psychedelics, certainly like the DMT, 5-MeO, which was just spoken about, is the disembodiment, the out-of-body experience, which at the psychedelic dose of ketamine, pretty much everybody has. Another thing I've noticed is people often describe an equanimity, an almost kind of Buddhist-like, non-judgmental quality, like very neutral. It's not good or bad or black or white. People often say, it is what it is, or that was. So what about the mechanisms? Like the classics, ketamine reverses the effects of chronic stress on the brain, the neuronal atrophy. So from chronic stress disorders like depression, addiction, anxiety disorders, increased neuroplasticity, increased number of branches and connections between the brain cells, which translates into increased flexibility and resilience in terms of our our thoughts, our feelings, and behavior. Also, normalization of functional electrical networks, increased signal diversity, increased function of the prefrontal cortex, normalization of the amygdala, downregulation of rumination in the default mode network, and ketamine disrupts what's called the anti-reward network, or the punishment center of the brain. It's a little center in the lateral habenula that sends out sort of punishing signals to negative signals to dopaminergic and serotonergic areas in the brain. In terms of psychological mechanisms, many of the mechanisms that have been discussed throughout the day can be seen with ketamine. Novel perspectives, insights, transformation, reconsolidation of maladaptive patterns, trauma, increased cognitive flexibility, enhanced learning of adaptive strategies, and motivation for change. Also, there are empathogenic effects of ketamine and pro-social effects, reconnection. There was a very interesting study that was done not too long ago, actually showing how ketamine can improve empathy both in mice and humans. I'll give a couple quick examples of some of the psychological transformations that I've observed in my practice. So one was a guy who had severe PTSD, depression, suicidal for almost a decade. He had fought in combat. A friend of his had died in the war, and he blamed himself for his friend's death. In his experience, he dissolved into the universe, became one with God, realized that he had God in him and he was part of everything, saw his friend who had been killed. His friend forgave him, and he forgave himself. And that was all in an hour. Another patient who had suffered from severe chronic depression for many decades, had a terrible abusive childhood, described going into the blood vessels in his body, into his brain, down the nerve cells, into the cells, into the molecules of his own mind, and then he explodes out into this black space, and there's nothing there. But then in the distance, he sees this little box, and as it gets closer, he looks into this black box, and in there is a 6-year-old boy in the corner in a fetal position, sad and afraid. And he reaches in and he holds the boy, and then becomes the boy and sees himself as an adult telling him that it's okay, that it wasn't his fault. He doesn't need to be afraid. We are finding, just like we are with the classics and MDMA, that ketamine appears to be transdiagnostic. So the more different indications we study it, it appears it could be helpful for many, many different things other than just depression. And that makes sense in terms of the mechanisms, the both neurobiological mechanisms and psychological mechanisms. So over the decades, 2 primary therapeutic frameworks have evolved. One, the biomedical approach, getting a shot of ketamine in the hospital, the lights are on, the TV, the nurse is walking by, you're just laying there. And in that model, it's focused on the neurophysiologic effects, the antidepressant effects, and the experience, the subjective experience, is an afterthought or usually seen actually as a side effect to be controlled, to be minimized. And then the psychedelic model, which puts particular importance on the subjective experience, the context, the set and setting. In the implementation of this treatment in Norway, over the years we've evolved to a combined biomedical and psychedelic approach, very similar to what's been called the Montreal model, developed by Kyle Greenway and colleagues in Canada, and David Arizzo worked also on fantastic paper about this recently. And that's a balanced biopsychosocial model where you try to combine the best of evidence-based medicine plus a psychedelic-informed treatment process. So not either or, but yes and. And that includes good screening, assessment, preparation, psychedelic treatment and integration, careful attention to the set and setting, the whole time combining the process with evidence-based psychotherapy, and then afterwards and between leveraging this neuroplasticity or this leveraging the neuroplastic window as an opportunity for change, augmenting standard treatments and other behavioral interventions. I'm sure many of you have seen the psychedelic drug development tracker from Psychedelic Alpha, with the countless number of different pharmaceutical companies developing various psychedelics for medical use. The thing is, in the bullseye is just Spravato, so S-ketamine. But racemic ketamine has been legal and approved for off-label use since 1970. And it's going to be many years, unfortunately, before these other psychedelics are fully implemented. I'll say a little bit about our Norwegian experience. So after a couple years of embattlement with the professional organizations and the medical board, we were able to open the first public ketamine unit in 2020. We first did it as an inpatient, then opened an outpatient unit. In 2023, the leader of the Psychiatric Association called for increased public access to ketamine in the public system. And this was the previous leader had turned me into the medical board for doing ketamine treatment. In 23, we started a network called the Norwegian Network for Rapidly Acting Antidepressants. It's kind of a strategic way to say psychedelic. And it's a group of about 100 consultant psychiatrists from throughout the country. We meet on a monthly basis. We discuss the research that's going on and stimulating this field. A couple months ago, we got a large grant for a randomized controlled trial to look at various maintenance strategies for ketamine. And importantly, this is going to include 10 hospitals in Norway, so every single major hospital in the country, all the health regions. And what this means is we actually designed the study in this way so that once we do this study, we will functionally implement ketamine into the entire country. So every person, wherever you live, will have access to free ketamine treatment. So in addition to doing this study, those units that we have to build and train will also be doing just clinical treatment for patients. So some of the research that's going on right now is we have a number of different ketamine studies in addition to that large one. We just started recruiting ketamine for alcohol use disorder in Tromsø, and are planning another one as well in the south. We have a working group looking at ketamine for eating disorders. After participating in the MAPS MP18 MDMA for PTSD trial, we did a site-initiated, publicly government-funded study, just a pilot for MDMA for depression. This is the first study ever in the world for that indication. So that's finished, about to be published. And we're doing a follow-up of that, focusing on young adults in a continuation of some work done by Eva Henny in Sweden. We have a psychedelic research group at the University of Oslo doing population-based studies. And we're in the early stages of a psilocybin-assisted group therapy study in people that survived cancer. The exciting thing about that one is one of the collaborators on this trial is the leader of the Norwegian Psychiatric Association. So it's come a long way. So I think that it's important that we recognize the psychedelic nature of ketamine, because I think it can help us in our effort to build this runway for all the other psychedelics on the horizon. It's important for us to establish the infrastructure, train people, involve the stakeholders in the health system, and also, more importantly, it's something that has been available the whole time. It's available for patients that are suffering, and patients need all the tools that are available. So I'll end on words that my father used to tell me often when I was a teenager, which is, learn from the mistakes of others, because you won't live long enough to make them yourself. Thank you.